So this patient's immunocompromised for multiple reasons: cancer and chemotherapy, right? So this is a big time problem. So, right? So we worry about gram-negative sepsis in these patients, right? We worry about if they're getting chemotherapy, how are they getting it? Is it through a port? Is it through like a Broviac? Not a Broviac. We don't call it Broviacs anymore, right? They're like an indwelling dialysis the tunnel catheter. It's usually not a tunnel catheter. It's usually a port, right? Like a metaport or some sort of chemoport, right? We usually give a third or fourth generation cephalosporin and an aminoglycoside like gentamicin, that we don't use a ton of gentamicin anymore. Or we could use a carbapenem, again, meropenem, imipenem, ertapenem. We would think about vancomycin, especially if we thought an infected port was involved, right? So that would be something we would think about in that patient. And the last patient is the 85-year-old patient with a recent 3-week hospital stay for urosepsis, now with diarrhea, altered mental status, white cell count, and CT showing pancolitis. So what particular infection do we worry about in this cat? Think about it. Diarrhea, recently treated with antibiotics. Pseudomembranous colitis and C. diff, that's right. Does the patient need an operation for their colon? Are they sick enough? And then this patient is going to need oral vancomycin usually, and or oral or IV metronidazole, right? And this person can get very, very sick very, very fast. These patients can be exceedingly ill, right? All right. So, what is a nosocomial infection or healthcare-associated infection? It's a localized or systemic condition resulting from presence of infectious agents and or its toxins that occurs in a patient in a healthcare setting, is not present on admission, right? Unless the infection is related to a previous admission. So if somebody didn't have an infection when they walked in the door and they get one while they're here, it's a healthcare-associated infection. Currently, 1 of every 25 hospitalized patients gets a healthcare-associated infection, so it's a big deal. Most are caused by bloodstream infections, right, from central lines, ventilator-associated pneumonia, C. diff, transmission of MRSA due to bad hand washing, and/or surgical site infections, which have to do with, factors associated with the operation the patient had. So how do we prevent them? Hand hygiene, contact precautions when patients have bad bugs, full sterility when inserting devices, right? And that's my job as well as your job. Doctor, you need a hat, you need a mask, blah, 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 blah. Establishing a prevention bundle for indwelling catheter infections, as well as mechanical ventilation, sitting the patients up, chlorhexidine, mouthwash, that sort of thing. And appropriate use of antimicrobials. And probably the 2 biggest problems are inappropriate use of antimicrobials and poor hand hygiene. And that's on all of us. I mean, you guys are probably much, much better about it than we are, but it's on all of us.
Blame the nurses.
No. I said you guys are better about it than we are. I just said you better than we are. And it's okay to remind each other about hand hygiene. Jason, don't forget to wash your hands, right? Oh, shit, I'm sorry, I forgot. Right? So fever is the most common finding that raises suspicion of infection. Cultures would be best obtained before antibiotics. Antimicrobial therapy depends on the pathogen, depends on the comorbidities of the patient, depends on where the infection is, depends on gram savings results and local resistance. Antimicrobial therapy should be instituted immediately when meningitis is suspected. Strep pneumo is the most common pathogen in severe community-acquired pneumonia. Staph aureus and resistant gram-negatives are frequently causes of hospital-acquired pneumonia. What else? Suspected intra-abdominal infection and soft tissue infection should involve a surgeon early. You need to be a little bit broader, a little bit more aggressive in immunocompromised patients. And then we think about fungal infection in patients with predisposing factors, on and off antibiotics in the hospital for a while, immunocompromised, TPN, things like that, okay? Okay, good.